Welcome to the deep dive. Today, we're moving out of, let's say, the abstract and into one of the most immediate and, frankly, high stakes areas of medicine.
We certainly are. We're talking about neurologic emergencies.
Exactly. This is going to be a deep dive into conditions with some of the highest mortality rates, things like stroke, traumatic brain injury, and that terrifying problem of increased pressure inside the skull.
It's a world where every single second counts. And for you listening to this to get a real handle on the material, our mission today is to really distill the critical knowledge. We need to go beyond just the textbook definitions.
And to do that, we need a framework, right? A way to organize this flood of information, because otherwise it can be completely overwhelming.
That's the key. Every symptom, every intervention we're going to discuss today, it all ties back to four foundational concepts, a blueprint for how to think about neurologic care.
Okay, let's lay out that blueprint right now. What are the absolute core concepts we need to center our thinking around?
The two top priorities are always perfusion and cognition.
Perfusion and cognition.
Right. Perfusion is the delivery system. It's all about how well blood carrying oxygen and glucose actually reaches the brain tissue. If that delivery fails, everything else starts to fail.
And cognition.
Cognition is the function. It's the mental processes, memory, language, reasoning that, make us who we are. In any neurologic crisis, one or both of these are immediately at risk.
So if perfusion is the fuel line and cognition is the computer, then we have two other concepts that are sort of the downstream effects, the things we can actually see going wrong.
Exactly. Those are mobility and sensory perception. If a part of your brain that controls, say, your left arm is starved of blood, you're going to see a mobility deficit. If the part that processes vision is damaged, you'll see a sensory perception deficit.
So a stroke would be a classic example of a perfusion problem, and a TBI might be a primary cognition problem.
Perfectly put. And they're all linked. A perfusion problem will cause cognitive and mobility issues. A head injury affects cognition and can cause swelling that disrupts perfusion. So you keep these four concepts in mind: perfusion, cognition, mobility, and sensory perception. It will help make sense of everything else we cover.
All right, let's start with the most common of these perfusion crises, the stroke. The term brain attack really captures the urgency, doesn't it?
It does, and it's intentional. We want people to think of it with the same urgency as a heart attack. A stroke is, at its core, an interruption of perfusion to a part of the brain, and that interruption results in infarction.
Infarction meaning cell death.
Cell death, yes. The brain is incredibly demanding. It's only about 3 pounds, but it uses 20% of all the oxygen and glucose your body takes in.
And unlike other parts of the body, it can't store any of that fuel.
It has no reserves. So when you interrupt that blood flow, even for just a few minutes, those brain cells begin to die. That's infarction.
And it's so important to remember the cross-wiring of the brain, the fact that the damage appears on the opposite side of the body.
Absolutely. We call it a contralateral effect. The major nerve pathways cross over in the brainstem. So if the infarction is in the right hemisphere of the brain, the weakness or paralysis, the mobility deficit, you see it on the left side of the body. It's a classic sign.
Okay, so when we talk about strokes, there are two fundamental ways this can happen: a blockage or a bleed.
Ischemic and hemorrhagic. Ischemic strokes, the blockages, are by far the most common. They account for about 80% or 4 out of 5 of all strokes.
So let's start there. What's happening in an ischemic stroke?
An ischemic stroke is a perfusion failure caused by an occlusion, a physical blockage. The result is anoxia, a total lack of oxygen, which leads to that cell death we mentioned. But it's important to break it down further because there are two main types of blockages.
A thrombotic stroke versus an embolic stroke. How should we visualize that difference?
I think the best way is to think about it in terms of geography. A thrombotic stroke is a local problem. It's caused by a thrombus, a blood clot that forms right there on the wall of the artery.
And this is usually due to some long-term chronic issue.
Yes, almost always.
Yeah.
The primary cause is atherosclerotic plaque. That's the buildup of fat, cholesterol, and other substances on the arterial wall over years and years. It narrows the artery. This is also linked to carotid stenosis, which is just the hardening and narrowing of those big arteries in your neck that supply the brain.
So because this is a slow process, the onset of a thrombotic stroke might be more gradual.
Often, yes. The symptoms can develop more slowly, maybe over several hours or even overnight. It's like a pipe that's been slowly clogging for years finally gets blocked completely.
Okay, so a thrombotic stroke is a slow, local clog. An embolic stroke is different.
Very different. An embolic stroke is caused by an embolus. This is a piece of matter, usually a dislodged blood clot, that travels through the bloodstream from somewhere else in the body.
So it's a traveling problem.
Exactly. It travels until it reaches an artery in the brain that's too narrow for it to pass through, and it gets stuck. The most common source for these clots is the heart, especially in people with conditions like atrial fibrillation.
AFib, where the heart isn't beating regularly.
Right, the irregular beat allows blood to pool in the heart's chambers, which can form clots. Then a piece of that clot can break off, travel up to the brain, and bam, the blockage is instantaneous.
Which means the onset of symptoms is sudden and severe.
Almost always. It's a very dramatic, very sudden event, unlike the often slower onset of a thrombotic stroke.
Okay, so that's the clogged pipe. What about the burst pipe, the hemorrhagic stroke?
The damage mechanism here is completely different. It's not about starvation. It's about pressure and compression. A blood vessel ruptures, and blood spills out directly into or around the brain tissue.
And that blood takes up space inside the skull, which is a big problem.
A huge problem. The pooled blood doesn't just cut off perfusion downstream. The mass of it physically compresses and irritates the surrounding brain, causing pressure to skyrocket.
And like with ischemic strokes, we break these down by location.
We do. An intracerebral hemorrhage, or ICH, is when the bleed happens within the brain tissue itself. Small arteries and veins tear open, often due to severe, uncontrolled high blood pressure.
And the other type?
The other is a subarachnoid hemorrhage, or SAH. This is bleeding into the space that surrounds the brain, the subarachnoid space. This is most often caused by a ruptured aneurysm.
An aneurysm being a weak spot, like a little balloon on the wall of an artery that suddenly bursts.
Precisely. And both of these, the ICH and the SAH, lead to those catastrophic pressure changes we'll talk more about later.
Before we get to the full-blown stroke, there's often this critical warning sign that so many people unfortunately ignore: the transient ischemic attack, or TIA.
The so-called mini-stroke. And I agree, that name really understates the seriousness. A TIA is a temporary neurologic dysfunction. It's caused by a brief interruption in blood flow. It's so critical because it's a massive warning that a major stroke is likely on its way.
And the key word there is temporary.
Yeah.
The symptoms go away.
They do. They often resolve in 30 to 60 minutes, almost always within 24 hours. And because people feel fine afterward, they think, oh, that was weird, and they don't seek help, which is a huge mistake.
So what are the key symptoms of a TIA that people should absolutely not ignore? Let's start with vision.
The visual symptoms are very telling. Things like sudden blurred vision, or diplopia, which is double vision.
Okay.
Also hemianopsia, that's losing vision in one half of the visual field, like a curtain coming down over one side, or even tunnel vision. These are all signs that the part of the brain responsible for sensory perception is being temporarily starved of blood.
And what about on the mobility and sensory side of things?
You're looking for sudden, one-sided, or unilateral deficits. Sudden numbness in the face, an arm, a leg, a sudden intense feeling of vertigo, like the room is spinning, that has no other explanation.
But the most alarming sign is weakness.
Unilateral weakness is the big one. A sudden facial droop, or if you hold your arms out, one arm suddenly drifting down. If you experience that weakness, even if it goes away, your risk of having a major disabling stroke in the next few days is incredibly high.
And then there are the speech issues, which tie back to cognition.
Yes, a temporary bout of aphasia, having trouble finding the right words or speaking at all, or dysarthria, which is slurred speech due to muscle weakness around the mouth.
Given how high the risk is after a TIA, there are tools to quantify it, right? Like the ABCD2 tool.
That's right. The ABCD2 score helps us determine the short-term risk of a stroke after a TIA. It's a way to standardize the assessment.
So let's break that down. A is for age. The cutoff is 60. Why?
Because after age 60, the cumulative damage to our blood vessels, the atherosclerosis, really starts to accelerate. Vascular fragility just increases with age.
B is for blood pressure, specifically 140/90 or higher.
Right. That indicates uncontrolled hypertension, which is the single biggest risk factor for stroke. It damages the inner lining of the arteries, making them ripe for plaque buildup or rupture.
C is for clinical features. Unilateral weakness gets the most points.
Yes, because weakness signifies a more significant blockage occurred than, say, just sensory symptoms alone. It suggests a larger territory of the brain was affected.
D is for duration of symptoms, and the other D is for a history of diabetes.
Correct. The longer the symptoms lasted, the higher the risk. And diabetes is a huge risk multiplier. High blood sugar directly damages blood vessels, big and small, throughout the body, including the brain. A high ABCD2 score is a siren. It means that patient needs aggressive, immediate workup and intervention.
Which brings us to those interventions. The goal is to restore and maintain perfusion. If the main problem is that atherosclerotic plaque, what are the options for clearing it out?
Well, you can go in and physically remove it. The traditional surgery is a carotid endarterectomy.
So the surgeon actually opens up the carotid artery in the neck?
Yes. They make an incision, open the artery, and literally scrape the plaque out. They physically remove the obstruction to restore blood flow to the brain.
That sounds pretty invasive. Is there a less invasive option?
There is. It's called carotid angioplasty with stenting. In this procedure, a catheter is threaded up into the narrowed part of the artery. A small balloon is inflated, which swishes the plaque flat against the artery wall.
And then the stent.
Then a stent, which is a small wire mesh tube, is left behind to act as a scaffold, holding the artery open. The choice between the two really depends on the patient's overall health and where the blockage is located.
Okay, so those are the mechanical fixes. What about medications to prevent new clots from forming?
That's where the pharmacology comes in. We rely heavily on antiplatelet drugs, things like aspirin and clopidogrel. They work by making platelets less sticky, so they're less likely to clump together and form a dangerous clot. For anyone who's had a TIA or stroke, this is usually lifelong therapy.
And we can't forget the foundational lifestyle management. You mentioned hypertension is the biggest risk factor.
It's non-negotiable. Controlling high blood pressure with diet, exercise, and medication is the most important thing you can do to prevent another stroke.
And for patients with diabetes.
Strict glucose control is vital. The sources emphasize a target glucose level around 100 to 180 milli-GDL. Keeping blood sugar in that range minimizes that ongoing vascular damage we talked about and ensures the brain has the fuel it needs to function.
Okay, so we've covered the crisis in the blood vessels. Now we need to shift focus to the aftermath, the damage to the brain itself. This is where we see those profound deficits in cognition, mobility, and sensory perception.
And this is where the terminology becomes really important. These aren't just, fancy words. They describe specific, devastating losses of function that tell us exactly which part of the brain was damaged.
Let's start with communication, aphasia. This is often one of the most difficult deficits for families to deal with.
It's incredibly difficult. And there are two main types. The first is expressive aphasia, also called Broca's aphasia.
And that's from damage in the frontal lobe.
Typically, yes, in the frontal lobe of the dominant hemisphere. The key thing to understand about expressive aphasia is that the patient's comprehension is intact. They understand everything you're saying to them.
So their cognitive input is fine.
Their input is fine, but their output is blocked. They know exactly what they want to say, but they can't get the words out. It's incredibly frustrating for them. They might speak in very short, halting phrases with immense effort.
Like the wiring from the thought to the mouth is broken.
That's a great way to put it. Now, the other type, receptive aphasia or Wernicke's, is essentially the opposite problem.
So here, the problem is with the input.
Exactly. The damage is in the temporoparietal area, and it affects their ability to understand spoken or written language. Their comprehension is impaired. They can often speak fluently, with normal rhythm and tone.
But the words don't make sense.
They don't. It's often called a word salad. The speech is fluent, but meaningless because they aren't processing the conversation's context. This can also lead to alexia, the inability to read, or agraphia, the inability to write.
Okay, let's move to the physical deficits, the direct impact on mobility. We need to be clear about the difference between weakness and full-on paralysis.
Two very important terms here, both referring to one side of the body. Hemiparesis is one-sided weakness. The patient can still move their arm and leg, but the limb is very weak and not very functional.
And hemiplegia.
Hemiplegia is more severe. That's one-sided paralysis, a complete loss of movement in the arm and leg on one side of the body. The severity really dictates the entire rehabilitation plan.
Beyond just strength, strokes can affect our ability to perform learned, coordinated movements.
Yes, and that brings us to apraxia. This is a really interesting one. Apraxia is the inability to perform a previously learned motor skill, even though the person has the muscle strength and the desire to do it.
Can you give an example?
Sure. You might hand a patient a comb and ask them to comb their hair. They understand the command, they can hold the comb, but they might try to brush their teeth with it or just tap it on their head. The neural program for the sequence of combing hair has been erased.
Wow, and what about basic balance and coordination?
That's ataxia. Ataxia is a lack of muscle control and coordination, often caused by damage to the cerebellum. It results in a staggering, unsteady gait. It profoundly affects a person's balance and their ability to walk safely. It's a huge blow to their fundamental mobility.
Some of the most fascinating and frankly bizarre deficits are in the realm of sensory perception and recognition. Let's start with agnosia.
Agnosia is the inability to recognize objects, even though your senses are working perfectly.
So you can see the object, but you don't know what it is or what it's for.
Exactly. A patient with agnosia might see a pen, and they can describe it. It's long, it's blue, it has a pointy end, but they have no idea that it's an object used for writing. The connection between the visual input and the concept of pen is gone.
But perhaps the most profound deficit of awareness is unilateral neglect. This is one that's really hard to wrap your head around.
It is truly mind-bending. Unilateral neglect or inattention is when a patient is completely unaware of one side of their body and the space on that side. It's usually caused by damage to the right parietal lobe, which results in neglect of the left side.
So what does that look like in practice?
A patient with left-sided neglect might only eat the food on the right half of their plate. They'll leave the left side untouched because, in their mind, it doesn't exist. They might shave only the right side of their face or put makeup on only the right side.
They don't even realize they're missing half the world.
To them, they aren't. That entire side of their universe has just vanished from their conscious awareness. It's a complete breakdown of sensory perception and self-awareness.
We should also quickly touch on the more academic deficits and the emotional changes that can happen.
Of course. We can see things like acalculia, which is the sudden inability to do math calculations. And then there's emotional lability. This is a really difficult one for families.
This is where the patient's emotions are all over the place.
Yes. They might swing from laughing hysterically to sobbing uncontrollably for no apparent reason. It's important to understand this isn't a choice. It's a neurologic deficit caused by damage to the brain's emotional regulation centers. And of course, amnesia, or memory loss, is a very common cognitive deficit.
Okay, so we've gone from the perfusion failure to the specific deficits it can cause. Now let's pivot. Let's talk about the mechanical threat, traumatic brain injury, or TBI, and the deadly problem of pressure that it often causes.
Right. Increased intracranial pressure, or ICP. This is a totally different kind of crisis. As you said, it's a physics problem.
A physics problem inside the skull.
Exactly. You have to picture the skull as a rigid, fixed box. It cannot expand. And inside that box, you have three things: brain tissue, blood, and cerebrospinal fluid, or CSF.
And under normal conditions, they're all in a delicate balance.
A perfect balance. This is the Monro-Kelly doctrine. If the volume of one of those three things increases, for example, you have bleeding from a TBI or swelling of the brain tissue, the volume of the other two has to decrease to keep the pressure stable.
But that compensation can only go so far.
It's very limited. The body can shunt a little blood out or displace some CSF, but once those mechanisms are maxed out, any tiny additional increase in volume causes the pressure inside that fixed box to spike exponentially.
And that rising pressure physically squeezes the brain.
It crushes the brain tissue and collapses the blood vessels, which cuts off perfusion. So a pressure problem quickly becomes a perfusion problem, leading to widespread brain injury.
Is there a specific condition related to just the fluid volume increasing?
Yes, that's hydrocephalus. It literally translates to water on the brain. It's an abnormal buildup of CSF in the ventricles. If something blocks the normal flow or reabsorption of CSF, that excess fluid acts like an expanding tumor, driving up the volume and the pressure.
When that pressure starts to climb, the body sends out warning signs. The classic late-stage alarm bell is something called the Cushing triad. Why is this considered such a critical and often final warning?
It's a late sign because it means the pressure is so high that it's starting to crush the brainstem. The brainstem controls our most basic life functions: breathing, heart rate, blood pressure. When Cushing's triad appears, it means the brain is on the verge of herniating or being forced down through the opening at the base of the skull. It's a catastrophic event.
Let's break down the three parts of the triad. The first is a sudden, sharp increase in blood pressure.
Yes, severe hypertension. The brain realizes it's being squeezed so hard that blood can't get in. So in a last-ditch effort to force blood into the brain, the body triggers a massive systemic reaction to jack the blood pressure way up.
And that leads to the second part, a widened pulse pressure.
Right. Pulse pressure is the difference between the top number, systolic, and the bottom number, diastolic. The body shoves that systolic number sky high to overcome the ICP, but the diastolic pressure doesn't rise as much, so the gap between them widens dramatically.
And the final, seemingly contradictory sign is a slow heart rate, bradycardia.
It seems contradictory, but it makes sense. That incredibly high blood pressure is detected by sensors in your major arteries. As a reflex, They send a signal to the heart to slow way down to try to lower the pressure.
Mhm.
So you get this classic ominous combination: very high blood pressure, a wide pulse pressure, and a slow heart rate. When you see that, you have to act immediately.
What are some of the earlier signs of rising ICP we should look for before it gets to that critical stage?
The single most reliable early sign is a change in the patient's level of consciousness, or LOC. It can be very subtle at first. Maybe they're a little more confused, a little sleepier, or harder to arouse.
What else?
A persistent headache is common, especially one that's worse in the morning. And projectile vomiting, often without any preceding nausea, that's a classic sign of pressure on the brainstem.
And there are signs we can see in the eyes as well.
Yes, if you look at the back of the eye with an ophthalmoscope, you can see papilledema, which is swelling of the optic disc. It's a direct window to the pressure inside the skull. You also see changes in the pupils. They might become sluggish or unequal in size, and impaired eye movements like nystagmus, which is that involuntary jittery movement of the eyes.
You mentioned in the outline that infants show different signs because their skull isn't fused yet.
That's right, their skull can expand a bit, which changes the picture. In an infant with high ICP, you'll see bulging fontanelles, the soft spots on their head. You might see the cranial sutures separating. Their head circumference might actually increase, and they often have a very distinctive, high-pitched cry.
Okay, let's link all this directly to traumatic brain injury. A TBI from some kind of external force is often what kicks off this whole pressure crisis.
Yeah.
Let's talk about the different levels of injury.
The mildest form, and the most common, is a concussion. This is a functional injury. You might not see anything on a CT scan, but the shaking or blow to the head has disrupted how the brain cells communicate. It may or may not involve a loss of consciousness.
But just because it's mild doesn't mean the effects go away quickly.
Not at all. That leads to post-concussion syndrome. This is where symptoms like headaches, dizziness, difficulty concentrating, and memory problems can linger for weeks or even months after the initial injury. It can be quite debilitating.
And there's a particularly dangerous situation that can happen with repeated concussions, especially in sports.
Yes, and this is critically important. It's called second impact syndrome. It happens when a person gets a second concussion before they've fully recovered from the first one. The result can be rapid, catastrophic brain swelling. It's often fatal, and it's why return-to-play protocols after concussion are so incredibly strict.
And at the far end of the spectrum of repeated trauma, we have a condition that's gotten a lot of attention recently.
Chronic traumatic encephalopathy, or CTE. This is a progressive degenerative brain disease caused by years of repeated head trauma. We see it in some military veterans and professional athletes. It leads to dementia-like symptoms, personality changes, and severe cognitive decline later in life.
When a TBI causes bleeding inside the skull, it forms a hematoma. We need to distinguish between the two main types.
The key difference is the location of the bleed, which tells you what kind of blood vessel was torn and how fast the bleeding will be.
So first, the epidural hematoma.
An epidural hematoma is bleeding between the dura, the tough outer lining of the brain, and the skull itself. This is almost always caused by tearing an artery. Arterial bleeding is high pressure, so the blood accumulates very, very quickly.
This is the classic injury where someone gets hit in the head, seems fine for a little while, and then rapidly deteriorates.
Exactly. They might have a brief loss of consciousness, then a lucid interval where they seem okay, and then as that hematoma expands rapidly and pressure spikes, they crash. It's a true neurosurgical emergency.
Now, contrast that with a subdural hematoma.
A subdural hematoma is bleeding underneath the dura, directly on the surface of the brain. This is usually caused by tearing the bridging veins. Venous bleeding is low pressure,
So the blood accumulates much more slowly.
much more slowly. It can be acute, happening over hours to days, but you can also have a chronic subdural hematoma, especially in the elderly, where a slow, insidious bleed occurs over weeks or months, causing very gradual confusion and weakness that can be easily mistaken for dementia or just old age.
To manage this kind of severe pressure, you need advanced monitoring and interventions.
Absolutely. The gold standard is direct ICP monitoring. A neurosurgeon inserts a small catheter or sensor through the skull into the brain to get a continuous, accurate pressure reading. That number then guides our entire treatment plan.
And if the pressure is dangerously high and caused by something like a hematoma,
Then you need to relieve it surgically. That's a craniotomy. The surgeon opens a window in the skull to get to the brain, evacuate the blood clot, and give the brain room to swell. It's a decompression procedure.
the outline also mentions a more specialized therapy for tissue that's been deprived of oxygen.
Right, hyperbaric oxygen therapy, or HBOT. This involves having the patient breathe 100% oxygen in a pressurized chamber. This dramatically increases the amount of oxygen dissolved in the blood, which can then be delivered to injured, oxygen-starved brain tissue. It can help salvage tissue that's at risk of dying.
We've focused so much on the acute crisis, the immediate life and death struggle, but for the survivors, that's just the beginning. The real battle shifts to recovery.
And it is a battle. They're often facing a new reality of physical disability, cognitive challenges, maybe even long-term mental health issues like depression. This is why recovery requires a massive, coordinated team effort.
The interprofessional team approach. This isn't something one doctor can manage alone.
Not even close. It's a whole team. You have the physicians and nurses managing medical stability, but then you have physical therapists, the PTs, who focus intensely on restoring mobility strength, balance, walking.
And occupational therapists.
The OTs are amazing. They help patients relearn the practical skills of daily living. They bridge mobility and cognition by working on tasks like dressing, bathing, cooking, everything you need to be independent.
And what about the communication and cognitive side?
That's where speech-language pathologists, or SLPs, come in. They work on everything from aphasia and cognitive retraining to swallowing problems, which are very common after a stroke. Then you have social workers and case managers who are essential for connecting the family with resources and planning for long-term care.
The source material really emphasizes that this care has to be patient-centered, especially when someone is dealing with a brand new, life-altering disability. What does that actually mean on the ground?
It means we have to fight against a one-size-fits-all approach. We have to start by asking the patient, what are your goals? For one person, it might be running a marathon again. For another, it might just be to hold a spoon and feed themselves.
So their goals drive the therapy.
Their goals, their values, their beliefs, it's about preserving their autonomy and dignity. And on a practical level, it means providing them with the tools they need to be safe and as independent as possible. Walkers, adaptive equipment, things like that. It's about respecting them as a whole person, not just a collection of deficits.
And in that acute phase, we need to remember safety precautions. You mentioned spine precautions earlier.
Critically important. If someone has a significant traumatic brain injury, especially from a fall or a car accident, you have to assume they also have a spinal cord injury until it's proven otherwise. That means immobilizing their spine to prevent any movement that could cause a secondary permanent injury.
Finally, we have to acknowledge the most difficult conversations: end-of-life care and the possibility of organ procurement.
It's a part of critical care that requires immense sensitivity. For a patient who has suffered a catastrophic, non-survivable brain injury and is declared brain dead, the process of honoring their wish to be an organ donor becomes part of the care plan. It's about finding life in the midst of tragedy.
Bringing this all together, there's clear mandate for prevention and for addressing health equity.
Absolutely. We know that risk factors and access to care are not distributed equally in our society, so our care plans have to account for that. But even more importantly, we have a duty to teach prevention. Simple things: eating heart-healthy foods, controlling blood pressure, wearing a helmet. These are the most powerful tools we have against these devastating neurologic emergencies.
This has been a really intense, but I think really necessary deep dive. We've gone all the way from the subtle visual changes of a TIA to the final crushing signs of the Cushing triad.
And if there's one core takeaway, I hope it's the ability to see these as two fundamentally different problems. The perfusion issue, like in a stroke, where the brain tissue is starving, and the pressure issue, in a TBI or with a bleed where the tissue is being compressed.
Recognizing those early warning signs, like that temporary unilateral weakness, is just as important as recognizing the late catastrophic ones.
It's all about time. The phrase brain attack is meant to convey that urgency. Every minute that goes by, more brain cells are lost.
So what does this all mean for you, the learner, taking this all in?
It means that immediate action is the only thing that can prevent or reduce permanent disability. Whether that's getting to the hospital in time for a clot-busting drug or getting to the OR for a craniotomy, time is brain. There is no simpler way to put it.
And this brings us back to the incredible specificity of the brain. Location is everything. The source material mentions that brain tumors are often classified as either supratentorial, which is above a specific fold of tissue in the main cerebrum,
or infratentorial, which is below that fold, down in the area of the cerebellum, and crucially, the brainstem. That area houses the control centers for our most vital functions: breathing, heart rate, consciousness.
Which leads us to our final provocative thought for you to take away from this deep dive. We've talked about how increased pressure causes the Cushing triad. So, how might the specific location of a problem, say a tumor growing directly in that infratentorial space and pressing right on the brainstem, how might that affect the presentation of Cushing's triad or severe ataxia differently? Might you see those critical signs earlier and more dramatically compared to a slow growing supratentorial tumor that's primarily affecting, say, language? Considering how location dictates symptoms is the key to moving from just memorizing facts to truly understanding neurological logic.